Now I call upon Dr. Shivkumar Chandrasekhar for his paper 1419. Last.
Respected chairpersons and delegates, I'm grateful for this opportunity to present the paper, Refractive Change over 5 years after cataract surgery with capsular excess overlap versus no overlap. As we all know, cataract surgery has evolved into a refractive surgery, and the recent advances have ensured achievement of emmetropia or a refraction target. One intraoperative factor having a great bearing on the refractive outcome is the capsular excess, which should be well centered and well sized. But the most important aspect of that is a 360-degree overlap over the optic of the IOL. The studies have shown the importance of this and also have demonstrated with imaging an IOL shift, decentration, and tilt, which happens because of lateral capsular back contraction. And with a partial or a lack of overlap, this can increase the effect. So the aim of the study was to compare the change in refraction over 5 years from that of the first month in patients with a 360-degree overlap and those without a 360-degree overlap. The patients were from the control group of a larger study, a 10-year-old study on pseudoexfoliation called the Aravind pseudoexfoliation study. And these patients underwent phacoemulsification with a foldable hydrophobic acrylic IOL in the bag implantation. These patients with senile cataract had no pseudoexfoliation, a pupil dilating more than 5 mm, no comorbidity, and a corneal astigmatism or less than 1 diopter. And in this study, there were two groups: those with 360-degree overlap seen post-operatively, and where the IOL had not covered by more than 1 clock hour with a partial overlap were in group 2. Only the patients who had attended all the follow-up visits of the original study were considered in the study, and complete refraction data had to be available for the first and third months, and first, third, and fifth years were taken for analysis. The following patients' data were excluded: those with intraoperative PCR, those with PCO, and those who had undergone YAG capsulotomy following PCO. So in the first group with the total overlap, we had 240 patients, and in group 2, we had 75 patients. The spherical equivalent of the refractive correction at 1 and 3rd months and the first, 3rd, and 5th years were taken, and the change in the spherical equivalent at each of these intervals from the first month was noted, and the percentage of patients with a hyperopic myopic shift or no shift was taken. When we looked at the average spherical equivalent at each visit, we found that with the overlap, the mean was 0.01 at the first month. There was a hyperopic shift of the mean to 0.18 at 1 year, and which gradually increased to 0.25 at the 5th year. Whereas in the other group, there was a wider variation, a variable refraction with 0.04, a myopic shift in the 3rd month, gradually becoming hyperopic, and finally ending at 0.13. And the change in the first year in the first group was significant. When we looked at the median also, both the medians in both the groups were 0, but the interquartile range was a little higher in the second group, suggesting a wider range of refraction, and there was a hyperopic shift which was to be noted from the first year onwards in the median in the first group. Looking at the amount of change also reflected the same thing. The change was usually the hypermetropic side in the first group, while it was myopic in the initial stages and hypermetropic later. When we looked at the shift of refraction from the 3rd month, at the 3rd and 5th year, we saw that there was a hyperopic shift as a majority, but it was more in the second group, and 1/3 of the patients or those with overlap did not have any change in refraction. When we looked at the percentage of patients with a spherical equivalent within 0.5, plus or minus 0.5 at 1 month and 5 years, we saw that it had dropped from 80% to 70 to 73% in both the groups, and they were comparable. And clinically, this would translate into the patients, 70% of the patients preserving their uncorrected visual acuity at 6/12 or better. Shift in IOL, decentration, and tilt can cause compromised vision, periodic changes in refraction and glasses, and therefore a dissatisfied patient. Decentration beyond 0.4 mm, a tilt beyond 5 degrees is found to be critical. In our study with the excess overlap, we found a hyperopic shift in the mean more within the first year from 0.01 to 0.8, but this hyperopic shift continued very gradually for the next few years. At the 5th year, it was 0.25, and the median also shows a hyperopic shift from 0 to 0.25. But in group 2, with a partial overlap, there was a myopic shift to start with, and thereafter a hyperopic shift. And the larger interquartile range of 1 diopter in group 2 also suggests that there was a wider range of refraction. Comparing the direction of the shift, we saw that 1/3 of the patients with overlap had no change. With partial, 20% had no change, and both groups had a hyperopic shift, but it was more so in group 2. The studies have shown a significant shift of optic in cases without an overlap, but there are no significant changes between a complete and a partial overlap. And that is because the study says that an area of cover is more important rather than the degree of cover. And so this explains the equivocal results of our study, as all patients are at least a partial overlap. To conclude, a 360-degree overlap of the CCC gives a better stability of refraction. There's a wider variation in refraction over time in group 2, but this is not significant. And the majority of the patients of both groups may not have a noticeable change in refractive error and visual acuity over a period of time. But having said this, further studies are needed to study the changes in higher order aberration and the quality of vision between both groups, as this may be what determines patient satisfaction. Thank you.